A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.
Did you know that the Centers for Disease Control report that there are almost 1.4 million people living with colorectal cancer in the United States? It's a cancer that's not always talked about and thought to impact people over 50. But in the last 30 years, the rate of cancers of the colon and rectum have doubled among adults younger than 50. Is this because older adults are taking precautions like getting colonoscopies and putting out those cigarettes? Why is there an uptick in cancer among younger people? We'll get to the life-saving answers and information you need of this edition on your Hometown Health Connection. I'm Samantha Latshaw. Welcome to your Hometown Health Connection. It is a sobering statistic that over 8% of cancer deaths are connected to the colon, with a 5-year survival rate of just 65%. Is it a preventable cancer, and what can be done to catch it early on? Joining us is Dr. Joseph Mills from General Physician PC. He's a clinical assistant professor and surgeon specializing in bowel disease, an expert in robotic and other minimally invasive techniques that can save your life, in addition to traditional surgeries. Dr. Mills, welcome. Thank you so much for joining us.
Oh, thank you for having me. It's my pleasure.
Tell me, what is colon cancer and what causes it?
Yeah, so colon cancer starts off usually as a polyp, which is a small alteration in the colonic mucosa or the rectal mucosa. And over around 8 to 10 years, it can transform or mutate into an abnormality such as a tumor or a cancer. What causes it? We're not entirely sure. We know it's some sort of a mix between genetics and our environment. What I mean by that is you may have a predisposition from your family, but there's also quite a bit of factors that go into it, from your diet, lifestyle, alcohol consumption, obesity, things like that.
And what are some of the symptoms, especially early on?
It's a great question. The symptoms can be quite varied. There's no real specific symptom that says this is definitely colon or rectal cancer, but things that we consider alarm symptoms are such as rectal bleeding, change in your bowel habits, the way that your stool looks, if it looks a little funny. You may have some abdominal pain or bloating, things of that nature. We would say, you know, come on in, talk to us, and we'll see if you need to have some further testing done.
How common is colon cancer, and is it more prevalent in certain ethnic groups?
Yeah, so over the last 30 years or so, those numbers have changed a little bit. And worldwide, there's quite a bit of variance in the colon and rectal cancer numbers. Here in the United States, though, we know that colon and rectal cancer is the second most common cause of cancer death in men, and it's the third most common cause of cancer death in women. And there's around 150,000 new cases that are diagnosed annually. So it's a pretty substantial number.
Wow, now we're seeing a huge rise in younger people being diagnosed with this. Why is that?
That's another great question, and I'd love to tell you that we had a good answer, but we're not entirely sure. What we do know is that under the age of 50, there's been a rise of about 2% over the last 15 years, from around 2004 when we started tracking, and that those patients under age 50, when they're diagnosed, they tend to be more advanced in their disease process as well.
Oh, perhaps is it the diet, you think, with the younger generation, that we're just more prone to just get the food quick? Is there a connection?
Yeah, I mean, I don't have any hard evidence to say that that's definitely the cause, but it's something that we're definitely looking at, and probably is playing quite a big factor. You know, fast food is on the rise, more preservatives in our food, things of that nature.
Wow. Who should get screened for colon cancer and when?
It's a little bit of a tricky question, but we say that at the very least everybody should be screened by age 50. Now, if you have a family history or if you have symptoms, then that'll change a little bit. It can be anywhere from 10 years before a family member that may or may not have been diagnosed with a colon or rectal cancer. In terms of some of the other ethnic communities, African Americans, we know, have about a 20% higher incidence of colon cancer compared to the white population, and that they should start screening earlier, usually at the latest age 45. But again, if there's any family history, that number will change. We usually recommend, talking to your primary care physician or we'd be happy to sit down and talk with you as well and see if there's any of those alarm symptoms or family history that may suggest that you should be screened a little bit sooner than the normal population.
Wow, yes, because we see many celebrities actually that were quite young and died at such a young age.
Yeah, absolutely. I think probably the one that's right on the top of everybody's mind is the Black Panther, Chadwick Boseman. You know, he was, I believe, 41 when he passed. So it's there, it's common, and it's something that we need to be vigilant about.
I'm sure a lot of people, though, are embarrassed to talk about this type of cancer.
Yeah, I don't mean to laugh about it because it's definitely not funny, but it is amazing how often, particularly women who come into our office and they say, oh my God, this is the most embarrassing day of my life. I can't believe I have to tell you about how I go to the bathroom and that I might be bleeding or something like that. But it's really nothing to be embarrassed about. It's what we want to hear. You know, we're there to help you. We want to, you know, potentially save your life, and we deal with it every day.
Right, this is what you do. This is normal.
Exactly.
So talk to me about the screening that goes into this for colonoscopy. Is that the best method, or perhaps are there other type of methods that perhaps like an MRI to be screened?
Yeah, so right now there are a number of modalities that we have available to test for colon and rectal cancer. The gold standard is still colonoscopy, and the reason being is that can be both diagnostic as well as therapeutic. And what I mean by that is it's diagnostic in the sense that we can look at the mucosa of the colon and rectum, and if we see, you know, a polyp or, God forbid, a tumor, we can biopsy it or potentially even remove it, which is the therapeutic portion of that. So you may have just prevented someone from, you know, dying from colon or rectal cancer, not right then, but 8 or 10 years down the road. So that's why it's still the gold standard. But there are other options out there, like you had mentioned, radiographic imaging. CT colonography is a modality that we can use if for one reason or other we can't do a colonoscopy or the patient's not amenable to it. There's also some stool-based studies that evaluate the DNA in the stool as well as look for any blood.
Doctor, a lot of people refer to colon cancer as the silent killer. Why is that?
That's an excellent point, and it's absolutely true. The reason being is if you think about your colon, and I often tell my patients this, I'm kind of like a plumber. You know, the colon's a tube, and that tube has a certain diameter to it, okay? These tumors or these polyps, they start off very small, like 2-3 millimeters in size. And over the period of around 8 to 10 years, they grow and transform. So during that period, this 2 millimeter little polyp that was just kind of on the wall has now become a very large sized tumor, but it's still not big enough to completely obstruct the lumen of your bowel. So you don't have any symptoms until either it starts bleeding because it can build its own blood vessels, or it gets large enough that it has blocked the passage and the tube can no longer pass things through it.
Right, because the symptoms that you mentioned earlier were so subtle, like just being bloated. That can come with a lot of things.
Yeah, absolutely. They're very benign symptoms, and they don't happen every single day. You may have an episode of rectal bleeding that occurs once, and then it doesn't happen again for a month, and that could have been your first sign.
So that leads me to my next question. Perhaps if you have a family member with a previous history of colon cancer or perhaps other cancers, should you be tested sooner?
Yeah, absolutely. And again, it's a little difficult to answer that question on the show because there's a number of factors that go into this. We have a very strict algorithm that we can go by, but typically we look at first degree and second degree relatives and whether they've had either precancerous polyps or a colon or rectal cancer. And then the screening usually involves moving up about 10 years and also decreasing the frequency or the interval between your colonoscopies. The standard is usually around 10 years if a patient has a normal colonoscopy, but if we find any polyps or lesions, the precancerous type, then we may make it 3 years, we may make it 5 years. With a family history or a patient that has had a past tumor, then we'll almost always decrease that interval from the 10 years down to 5.
We'll have much more on colorectal cancer. Before our short break, a reminder that you can connect with Dr. Joseph Mills at General Physician PC at 1150 Youngs Road in Williamsville or 888 Center Road in West Seneca. Their phone number is 716-636-9004 or online at gppconline.com. Ahead, more reasons why putting off that colonoscopy is not a good idea.
Buffalo Healthy Living magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living magazine all over our hometown or go online anytime at buffalohealthyliving.com.
Welcome back to your Hometown Health Connection. I'm Samantha Latshaw. Before we continue our conversation with Dr. Joseph Mills, let's hear from someone who shares their story on how early detection of colon cancer can save your life.
Going back about 15 years ago, some cousins were having issues with their stomach and went for colonoscopies and discovered that they had Crohn's and ulcerative colitis. I was having some of the same issues. So I decided to contact my doctor, and they recommended a colonoscopy, which at the time was 35, and they say you shouldn't get one, start around 50. So I was real early with that. They did the colonoscopy, found out that I had the Crohn's and ulcerative colitis also. And I've been going through the colonoscopies just about every year. Just recently, I've been going every 2 years. And it's something that can come on fast. And as they said, with having those diseases, you run a greater risk of having cancer later on. But if you stay up with it, you have a greater cure rate. Also, recently, my mother had just passed of colorectal cancer, and she also went for her screenings. And it's something that can come on very quick. It's not as bad as what everybody thinks it is. I mean, like I said, over the last 15 years, I've probably had 10 or 11 of them. And for the procedure itself, it's real easy. You don't feel a thing. You're in and you're out. The prep, you get used to it. It's not bad. But the preventative measure and going and getting it is just, astronomical what it can do for you.
So I was 25, much younger than the normal age. And getting that colonoscopy led me finally to the answer of my Crohn's diagnosis, which was life-changing because I was finally able to have answers to everything that was going on and get me on track to, the treatment I'm on today. With my uncle, he was at the age of just getting his normal colonoscopy screening, and that's how they found the colon cancer. And so he had to go through some surgery and chemotherapy and those treatments, but all very successful, thankfully, which led him to be able to still participate in lots of family events, weddings, things like that, which has been the same thing, obviously very life-changing as well. So yes, he was a father figure to his granddaughter, my cousin, and he was actually able to walk her down the aisle at her wedding this past year, which was a very significant, event, obviously, for them and for all of us to see. Absolutely. I'm very passionate about it and love to spread awareness. And I think, there's a stigma around people reaching out for the things that they need sometimes. And so I think it's so important to get out there and get your regular treatment.
When it first happened, I'd had a stent put in my heart. And they put me on blood thinners. And 3 or 4 days later, I noticed blood. So I went to the hospital, they put me in the hospital, and they did a colonoscopy and found the cancer. Dr. Mills came up, I guess he was on call, or he came up, he talked to us, explained everything to us, and we felt real comfortable with him, so we stayed with him. He made us feel very comfortable.
He called me a couple times at home just to fill me in on everything, and
when is that normal, do you find, for a doctor?
No.
Yeah.
He kept us informed the whole way through.
He made you feel like everything was going to be all right.
Yeah.
No matter what happened, we'd be okay.
Okay, doctor, so you've received the news, you're diagnosed with cancer. What does that look like?
So obviously it's a very traumatic news to the patient and their family. Their first reaction is usually fear. You know, they often think that this is a death sentence. You know, they're worried about explaining this to their family, what they're going to go through. There's a million thoughts that go through their mind. And oftentimes when I talk to my patients and I have to break the news to them, I tell them, you know, a lot of what we're going to talk about after this, you may not remember or you may not understand because all you are focusing on is the news that I've just told you, you unfortunately have cancer. So, you know, we give them our numbers. Sometimes we even give them our private number and we say, call us at any time with any questions that you have about what we talked about so that we can go back through this and you can completely understand what you're going to experience moving forward. So I think that that's really important for the patients and their family.
Absolutely, really holding their hand through this process.
Absolutely.
What does treatment option look like? Do they receive radiation like other cancers?
So that varies. It depends on whether they have colon or rectal cancer. We'll start with colon cancer. I think that's a little simpler and straightforward. Depending on the stage, there's 4 stages, you know, 1 being the best, 4 being the worst. Depending on the stage, will dictate whether or not we need to do a surgery up front or potentially chemotherapy, and vice versa. Sometimes you need to do the chemotherapy first, followed by a surgery. With rectal cancer, it's a little bit different. Radiation can be involved depending on the stage of the tumor. And sometimes you need to have chemo and radiation and then surgery, or surgery and then chemo and radiation. Sometimes if we catch the tumor soon enough, we can just do a surgery and that's all you need to have.
Now there is a 1-day procedure, but it's specific to a certain stage or type, correct?
Yeah, so there is a robotic procedure that myself and the people in my group do, where if it's an early stage rectal tumor, we can actually use the robot to go transanally through their anus. We bring the robot through and we can dissect out the tumor and close it, and patients have usually no pain, no bleeding afterwards, and they can go home either that day or at latest the next day. And robotic surgery in itself has kind of revolutionized colon and rectal surgery. It's not uncommon for patients to undergo a robotic colectomy or a resection of part of their colon and go home on post-op day 2 or post-op day 3. So the length of stay in the hospital is dramatically improved with some of our newer techniques.
I'm sure a lot of people, you know, they're scared if they get this diagnosis, am I going to have to wear a bag the rest of my life?
Yeah, that's an excellent question. I'm glad you addressed that, because that's probably the thing that I deal with most in these discussions is their first question after they hear that they have colon or rectal cancer is, am I going to be okay? And the second question usually is, am I going to have a bag? I don't want to have a bag. I don't want to die with a bag. And the great news about colon and rectal cancer, and I often tell my patients that this is the reason I focused my career on colon and rectal surgery, is usually it's a very survivable disease, particularly if we catch it early. With regard to the bag, it's very rare in colon cancer that we have to give patients a colostomy bag. It does happen from time to time, but usually, like I said, it's uncommon. For rectal cancer, that goes up a little bit, but even that, it's not every patient. And if they do have a bag, it's usually not for life, and we can reverse it after a couple of months once our surgery has had a chance to heal and the patient has completed any additional chemo or radiation that they may need, and they're feeling better. We can go back and get rid of that bag and get them back to their normal life.
Is the bag partly because of a certain stage of how far along the cancer has progressed?
It can be. It can be part of that. If the patient comes in with a more advanced tumor, we may have to what we call divert them or bring up a piece of the bowel that's in front of the tumor, so that, like I said before, you know, I'm kind of like a plumber. If the pipe down the line is blocked up, we may have to bring a piece of the pipe up before it to allow them to be able to move their bowels and eat and drink comfortably while they get treatment for that tumor, and then we go back and get rid of all of that. The other part of it too is sometimes, you know, I go back to the plumber. If I'm taking out a bad section of the pipe, okay, and I'm hooking up to 2 good pieces of the pipe, just like every other plumber, we worry that that pipe can fall apart. Sometimes we give people the bag to protect our anastomosis so that they're healthy and good and they can heal completely, and we go back in a couple months, make sure their anastomosis is still intact and healthy, and then we get rid of that bag and they move on with life.
Again, so for another reason to see you in due time.
Absolutely, absolutely.
Now, I'm sure we've all seen the commercials for the Cologuard with the cute little cartoon animation, right, to get you to get tested.
Yeah.
What are your thoughts on Cologuard? Is this something that actually is helpful in diagnosing, or any other virtual type test?
Yeah, so Cologuard is a really hot topic right now in my field, colon and rectal surgery. And what Cologuard is it's a combination of 2 tests where it looks at the DNA of the stool as well as if there's any blood products in the stool. And it's a non-invasive test, which patients love, so they can, you know, send off a stool sample, mail it off, and you know, a little while later they get a letter back saying, you know, it was either positive or negative. And it has a very high sensitivity for detecting colon and rectal cancer, around 93%. And people hear that and they think, this is great.
Right. You don't have to drink the yucky stuff.
Exactly, exactly. There's some caveats to that though. The biggest one being is it only picks up around 42% of those little precancerous polyps that we were talking about before. And if you ask most endoscopists, most of us colon and rectal surgeons out there, why we do colonoscopies, it's not really to find the cancer, it's to find these polyps before they become cancer and remove them. So, you know, Cologuard only picks up around 40% of those. So that means 60% of these little polyps go undetected. The other thing with Cologuard is it has about a 40% false positive rate. So imagine being this patient, you send off your stool study and you get this letter back that says your test was positive. I'm sure your immediate reaction is fear and that you now have cancer. So the follow-up to that is you have to have a colonoscopy anyways. And 40% of the time it'll be negative, which is great, it's excellent, but this patient has gone through this traumatic experience of believing that they have something, you know, potentially bad going on. So I think Cologuard is absolutely the future. I just don't think it's the best test that we have out there right now. And on top of all of that with Cologuard is it's only recommended for average risk patients at age 50. So that means the healthiest patients are the ones that they recommend it for. And I would say in my practice, those are probably the last people I would use it for. I reserve Cologuard for patients that have underlying health issues that prohibit them from being able to undergo a colonoscopy, or patients that just say, I'll never do it, I'm never getting this test done, I don't care what you tell me, I would rather die than have a colonoscopy. And those are the patients that I would say, okay, great, we have this study, but here's the information, or this test, but here's the information so that they know going into it what to expect and the pros and cons of it.
Do people put off getting a colonoscopy?
Yeah, absolutely. Even some of my family and friends that you know, have come to me in confidence, and I recommend, you know, they should get it looked at. They don't want to go through it. Nobody wants to go through the prep of doing the colonoscopy, where, you know, they have to spend a day going to the bathroom and drinking some stuff that doesn't necessarily taste great, and not being able to eat or drink the things that they want. But like I tell all of my patients, the worst part is the prep, and it's really not that bad anymore. And once you're through it, the easy part's the colonoscopy. You get to take a little nap, we serve up some cocktails, you get to go to sleep, and you're done.
Right, who wants to drink the yucky stuff, but then you have peace of mind though, right?
Absolutely. It's a small price to pay for potentially, you know, saving your life and staving off the need for more aggressive treatment down the road.
So I'm sure part of the fear perhaps of a colonoscopy is, am I awake?
Absolutely. That's probably the number one question I get as, you know, we're getting ready to start the procedure. They look and they say, Doc, I'm not going to be awake for this thing, am I? And the good news is no.
So you don't even know know what's going on.
Right, right. You may be a little bit awake, so we call it like a twilight sleep or a dream state where you can respond to us and you're not completely out as if it was general anesthesia for a major surgery. But usually patients tell me the last thing they remember is being wheeled into the room, and then the next thing they remember is when they wake up and they're in the post-op area and everything's done.
That's great. I hope that helps to calm a lot of fears and perhaps delaying a colonoscopy.
Absolutely. It's really not bad. I tell patients that, every day when I scope, I say, look, there's nothing to be nervous about now. The hard part's over. You're just going to take a little nap and you'll wake up. We'll get you off to some breakfast or lunch and it'll be great.
Perfect. How long is the procedure itself?
On average, I'd say anywhere between 15 and 20 minutes. That's my time. The time where you're in the room maybe a little bit longer, but it's not long at all.
Now, are there any risks involved with a colonoscopy?
Yeah, that's another important question. There are some risks involved. The two biggest ones that I tell all my patients about is, number one, there's a risk of bleeding, particularly if I do have to remove one of these polyps or I see a lesion in there, God forbid, that I have to biopsy or potentially even take off. And the second one is probably the scariest one, and there's always a chance we can put a hole in the colon when we do this. And the reason I say that is because, again, it's a tube that we're putting the scope through. So if you've had previous surgery or you have a little bit of a curvy colon, you can put the end of the colonoscopy through the wall of the colon. It's very rare. It happens less than 1% of the time, but it's one of those things. As a colorectal surgeon, I feel obligated to tell every one of my patients because accidents do happen, and I would like them to know ahead of time that it's a possibility. But again, it's very rare, less than 1%.
Okay, it's the risks, right? Very low compared to what could happen if, God forbid, you don't catch it in time.
Absolutely, absolutely. Risk reward is very high for this.
Wonderful. Now, as far as a story perhaps that you, in your personal experience, where early detection saved someone's life, can you talk to me about that?
Yeah, absolutely. I've had a number of patients that were quite young, under the age of 40, that came to the office because they thought they had a hemorrhoid, or there was a couple that had some rectal bleeding or a change in the way that their bowel movements looked, and I evaluated them and unfortunately found cancers on them. The good news was they were early. They got treatment very quickly. They've done quite well, and they're back to their normal life with almost no change and very little consequence because of it.
You can connect with Dr. Joseph Mills at General Physician PC at 1150 Youngs Road in Williamsville or on 888 Center Road in West Seneca. Their phone number is 716-636-9004 or online at gppconline.com. Don't become the next colon cancer statistic if you need to have a colonoscopy. Get it done. And remember, prevention is key. I'm Samantha Latshaw. Thanks for watching. Stay safe and be well.
A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.